next speaker is Dr. Manisha Rathi. She is senior professor in RIO Rohtak. So she is delivering her talk on low cost, affordable eye care and blindness. Dr. Manisha.
Okay. Thank you so much for including me in this. And I am really happy to see all the wonderful speakers, and a lot of points which were to be covered by me have already been covered. This is a topic close to my heart: low cost, affordable eye care and blindness. First of all, why are we interested in this topic at all? Because see the magnitude of the problem and the global impact. It affects many households, many cities, many states, many nations and the world as a whole. Even a developed nation is not free from the scourge of visual impairment and blindness. The reasons may be different. More than 2.2 billion people have either a vision impairment or blindness. And the maximum cause of vision impairment in the world is uncorrected refractive errors. 36% of the people who have refractive errors, visual impairment, have access to an ophthalmologist or to spectacles, and 17% only with those with cataract have access to medical facilities. There are socioeconomic differences, regional and socioeconomic differences. The countries which have a lower per capita income have a 4 times more incidence of visual impairment and blindness. All these studies are from the last 5 years only. So what is the impact? The impact may be social, financial, personal. If it occurs at a very young age, there will be developmental problems, such as delayed motor, language, emotional, social, cognitive development, which will finally lead to underperformance and academic underachievement. If it happens in early adulthood, then the quality of life is affected, and a lifelong effect of loss of employment, which affects the whole family as well as the individual, and there may be rates of increased worthlessness or depression and anxiety. If it happens in older age groups, there will be social isolation. There may be falls due to decreased vision, fractures which are very difficult to heal, so they may be put in assisted caring facilities earlier, which again has a huge financial impact. So the economic impact is enormous, and it's about US $411 billion. I don't know about you. I don't know how many zeros are in that figure. If we convert it into Indian rupees, how many zeros will be in those crores? I am not aware, but it is a staggering amount. So what are the strategies? We can't just take it that this is a global phenomena and it happens more in poorer nations. What are we doing about it? The effective interventions are you can promote, prevent eye health care, or treat, and finally if there's irreversible visual field loss or vision loss, we can rehabilitate. Each of these are important. Many things such as trauma with increased education to the public, and infections, if treated early, can prevent long-term complications. Traditional medicine should be discouraged without any supervision. Perinatal health should be improved. Nutrition-based diseases can also be cured, and self-medication should be avoided. Early detection is very important in irreversible blindness. The number one leading cause of global irreversible blindness is glaucoma. So screening for glaucoma and diabetic retinopathy, there are many nationwide and statewide programs for that. They are crucial to prevent blindness in patients. And of course, visual impairment, the leading cause is spectacle loss, lack of spectacle access to patients. So we should start screening for refractive errors in a younger age group and in an older age group as well. Quality surgery should be provided for cataract. So the leading cause of treatable blindness in the world remains cataract, whichever the country, and irreversible remains glaucoma, and now followed by diabetic retinopathy in a lot of countries. Dry eye, conjunctivitis, blepharitis, while they are not blinding, can really provide discomfort to the patient and have symptomatic difficulties which may interfere with their work. So it's important to treat these conditions as well. We are not just aiming to promote blindness, but the quality of life as a whole. And visual rehabilitation, if all is lost in the vision, we can still have visual rehabilitation. There's a WHO response which was adopted at the World Health Assembly in 2020. This was guided by the recommendations of the WHO World Report on Vision 2019 and resolution on integrated, people-centered eye care. This is IPEC, including preventable blindness and visual impairment. And the key proposal is to make integrated people care centers and ensure widespread. There's widespread, there's a W missing from this. Normally I leave a slide out so that somebody can point out, but this is a postprandial session in which people may be sleepy, so I'm pointing out the deficiency. A W is missing. So widespread, just to wake us up, widespread implementation. The report and the resolution, Dr. Basu has just told you how reporting, what indices are taken and how reports, because it's important to implement and to see what is happening. It's not enough to just put it out there. You have to assess it, improve it, and make sure it works. So some of the WHO key areas are monitor the global targets. They have been set for 2030, and on integrated people eye care centers, the reports are done, eye care indicators are taken, and the measures which are helpful. So we observe World Sight Day as an annual event so that it reminds people that sight is important. Although every day, every moment, from the moment you open your eyes in the morning to closing them at night, you know sight is important. You support integration of eye care and health systems. Then the eye care for health systems guide for action, the package of eye care interventions, and the eye care competency frame. The eye care, there are several tools which will help. So several toys at our disposal. Eye care situation analysis tool, assessment of diabetic retinopathy, assessment of glaucoma, refractive services. As you can see, these are the 3 leading causes globally of visual impairment and loss. Assessment of rehabilitation services. There's a myopia ed tool, which is a mobile health toolkit for myopia to increase health literacy, and graphics which promote healthy eye habits. So for cataract and glaucoma, we right now have the World Glaucoma Week, which we are observing. We have conducted eye camps, radio talks, glaucoma walks, distributed caps, poster competition, slogan competition, all to encourage, and have been doing screening for 40 plus or susceptible individuals. So this was a screening we did at ICCUS camp. Yes, patients are very happy to pose because they only said, one of them suggested these ladies, कहते जी ये क्या photo खिंचाई, ऐसे करो जी. So he took a picture like this, and this was 825 patients screened, and mobile number of my student was Dr. Anshu Khatri and Dr. Sakshi SR. These mobile numbers were distributed freely that they will contact. They said, please give us the address. We don't know where to come. They are only 50 kilometers away from us. So we have given, after the mobile number, there is a great sense of security that we will be seen. So they are coming to the OPD. Even now if I am here, patients are landing up at the OPD to get screened. Small incision cataract surgery is affordable, effective, and this is a study published by us because the main concern may be surgically induced astigmatism, so this may be minimal. This is an elderly patient. You can see hypermature cataract ready to burst, the zonules are weak, the capsule is weak, so I have just done the chevron incision because this patient had 0.25 with the rule astigmatism. At the end he had 0.25 against the rule astigmatism, which is considered to be beneficial nowadays. And this person was not concerned about astigmatism. The cause was lack of finances and lack of people to bring them to the hospital. So this surgery was done after staining the capsule. You can see the release of fluid, and this is the calcium. The whole lens is moving. It's a solid lens, so you have to be careful. I've completed the rexes, and now this division. My main concern was to bring this nucleus out and not let it go back, which SICS is more forgiving in this respect. And of course, indigenous IOL was donated by us. So these are the expectations. You know, one-to-one, people will see us, and this is how it will be. The reality is this. And of course, the right picture at the end is our OPD on any given day. And because of this, we are lucky. We are blessed we have this many patients coming. And thank you so much for giving me this opportunity. Thank you, sir.
Thank you, Dr. Manisha, for wonderful talk. And I think we should promote low-cost, affordable services to the community, and these services should be available to even to the remotest area. So thank you very much.
Thank you.
Any queries from
please ask something. No, and the eye camps are being done in our institution. The eye camps are being done. So for patients who are below 50, phaco is being done.
No,
but above 50...
Is there any guideline regarding doing phaco? Is there any guideline?
No, we have not received for the eye camps. Basically, we are documenting what the success rate is and monitoring closely. Senior consultants are always there. This is done on Sundays. You know, you get, supposing 100 patients. So 25 patients will be done on each Sunday, and in 2 shifts, leisurely, autoclave being used properly, disposable like any other patient. And if the patient is like this, then we prefer to do SICS. And in a younger patient or a patient who wants a specific kind of lens or whatever, that is also donated by them, they can choose. They call it laser wali surgery, which is a misnomer, but that is also available.
Regarding guidelines, it is very clear. NPCP program gives 1,000 for each free surgery. Of course, it is not being paid to the medical colleges. For government hospital, it is 1,000, and for NGOs and private hospitals, it is 2,000 per surgery. Whatever you can do in that much money, you can. In civil hospitals of Haryana, we are doing phaco with hydrophilic foldable within this budget.
So we can plan surgery according to the affordability of the machinery, equipment and other logistic and consumables present in our institutions. Government of India is giving the fixed amount as Dr. Jagdeep told us. Thank you, Dr. Manisha. We should promote low cost affordable eye care services to the